Hello everybody. Welcome to tonight's a little bit delayed starting Virtual Global Spine Conference. I was a little bit, it was my fault because there is a daylight saving change, and our global community, we are living in different time zones. Even me and my today's guest is living in a different time zone. And so I'm sorry for this delay. So I'm beyond thrilled to introduce my guest from today. I know him since 16 years. It's Dr. Jarkko Halme. He's an orthopedic surgeon, and we've shared the same employer 16 years ago in Switzerland, in Basel. And we both have a very similar background because our mothers are from Finland, and Dr. Halme is now performing university academic spine surgery in Finland at the Kuopio University. And I met him last year in person, and I invited him to be my guest. And today is the day, and I'm really happy, Jarkko, that you found the time because it's midnight in Finland. It's 11 o'clock here in Central Europe, and it is always hard to give a talk. But I guess it's a beautiful winter night outside in Kuopio in Finland. And please, Jarkko, I'm looking forward to your talk.
Thank you, Alexander, for the kind presentation and introduction. Yeah, I'm happy to be here, and thank you very much for the invitation. This is a pleasure for me, and also an honor to me to have this, let's say, international audience online, hearing something about rheumatoid arthritis and its role in posterior lumbar fusion, which is a bit, let's say, different topic because, we all know rheumatoid arthritis and its role in cervical spine and in axial instability, but you probably haven't heard a lot about rheumatoid arthritis and lumbar spine. What's happening there in the course of the disease? And I'm going to shed a bit light in that in form of case-based discussion. I have been treating spine patients several years now, looking back of about 20 years experience with spine patients. Part of that also together with Alexander, as you said, from those times in Basel. So let's start this. First, of course, my disclosures. I'm using implants as a spine surgeon, and then so I have a few contacts with a few companies. And all these cases that I am presenting today are my actual patients. I have not always operated them by myself, but they are my patients in the end. So rheumatoid arthritis in general, this is not a very seldom disease. We have roughly 20 to 23 million people worldwide suffering from rheumatoid arthritis, a very significant amount of people. And we know that it's more common in Europe and in North America than in Africa and in Asia. And we in Finland happen to be one of the worst countries when it comes to rheumatoid arthritis. The incidence is more than 40 patients per 100,000 people per year, which is, well, if not the biggest number in the world, very close to that at least. Compared to Japan, where they have only 10 to 15 cases per 100,000 people per year. And as you know, the rheumatoid arthritis nowadays is a very different disease than it was when I was studying medicine in the 90s. We were still, or people at that time were still using gold salts. Methotrexate was there, but these so-called disease-modifying anti-rheumatic drugs, the modern ones, the antibodies and the antibody-like drugs were not available at the time. The first one was Remicade infliximab, introduced in 1998, and then very many others followed, and as I said, they then changed the course of the disease greatly, and we now have much less severe causes and much less need for rheuma surgery than back in those days. But then, of course, there are seropositive and also seronegative patients, and the seropositive patients still might have very severe causes, and the disease haven't gone anywhere. The disease is still there, but we just can modify its course much better than we could, let's say, 30 years ago. Well, rheumatoid arthritis is a disease of joint capsules, synovial tissue, and ligaments around the joints. And it occurs especially in joints with large and multidirectional range of motion and complex synovium, like in hand and wrist joints. And of course, due to that reason, also the axial cervical spine, where it then can very typically cause the anterior atlantoaxial instability, which then occurs at least in 20% of all rheumatoid arthritis patients. Not everybody are very symptomatic, but many, as you know, are. And also subaxial cervical instabilities with subluxations and spinal stenosis below the axial spine are common too. And as you can see in the cases that I'm going to present soon. But then, as I already mentioned, the rheumatoid arthritis is less well understood in lumbar spine. We know that it affects the facet joints also there, and it causes effusions and erosions in those joints. But, in lumbar spine, we tend to think that the rheumatoid arthritis patients, they have more osteoporotic changes and fractures. But there are signs that rheumatoid arthritis weakens the fibrocartilaginous contact between the disc and the end plate, causing very distinctive changes and pathologies in lumbar spine. And we know due to that rheumatoid arthritis patients have much more spondylolisthesis in lumbar spine than patients without rheuma. That means over 40% of all rheumatoid arthritis patients come with spondylolisthesis at some point. And the spondylolisthesis and scoliosis tend to be much worse in those patients who are more difficult to control, where the disease have a more severe course and the drugs are not working as they should. And then we know that after lumbar fusion surgery, rheumatoid arthritis patients have much higher risk for adjacent segment disease and other complications also requiring revision surgery. This has been shown newly in a global spine journal. There was a study from Rochester, from Mayo Clinic, from 2022, where they checked over, I think, 3,000 or almost 4,000 rheumatoid arthritis patients and compared them then with equivalent controls. And they noticed that, for example, the risk for surgical site infection in rheuma patients was 2.29 times higher than in non-rheuma group, so significantly higher. And then the risk for implant-related complications was almost 4 times higher in meta-analysis, as well as the risk for pseudarthrosis. It was 2 times higher, even though this risk was not quite significant compared to the non-Rheuma group. And then there was also a tendency to a higher risk of adjacent segment disease. In this study, it was not so very well seen. I have seen other studies where the adjacent segment disease risk was much higher, but in this meta-analysis, it was for some reason only twofold. I do not know exactly why it was here a bit lower than in some other studies. So after this short general introduction to the rheumatoid arthritis, I will then, well, let's say, start with the first introductory case. It's about 56 years old IT professional, female, working in an office with a, let's say, modern, normal body shape with a bit obesitas and the diabetes, type 1, under control. She took very good care of her glucose values, and then she also had a Sjogren syndrome, which is a very common, or let's say it's common to have another inflammatory diseases when you have rheumatoid arthritis, so it's not very seldom. And this patient had a seropositive erosive rheumatoid arthritis since 1983, and rather severe or active disease despite several different medications, namely azathioprine and methotrexate and hydroxychloroquine and rituximab, tofacitinib, etanercept, lots of these different, also modern and very effective drugs. She had numerous local intra-articular and peritendinous corticosteroid injections, and had undergone already several hand and foot surgeries due to the rheumatoid arthritis, but her major joints, hips and knees and elbows, were okay. But then she had this L4 degenerative spondylolisthesis and L4-5 stenosis, which were decompressed and fused in May 2019, which made her quite satisfied for the coming 2 years. This is the image 3 months after that fusion operation. Well, this was not performed by me. I do not recognize these pedicle screws, but as I told you, she was happy after this operation. Until then, only 40 plus months post-operative, the images looked like this. She was experiencing back and leg pain again. So you see, there has something happened in the fusion area. We see that the disc has gone and there seem to be erosions in the end plate of L4 and L5. The allostesis has increased, and when we look at the screws, they seem to be loose. There are halos in L4 and L5 screws around them. So obviously we can say this was, after all, not fused because something has happened between those two vertebrae. So these were the images then that were made, and you can see here on the left the multiplanar reconstruction CTs, and then the MRI on the right. And I would like to highlight the sagittal CT image, where you can very well see these, I would say, rather usual erosions of the end plates L4 and L5, which are common for rheumatoid arthritis. And then in the MRI, you see this disc that seems to be rolled backwards into the spinal canal, which can be seen in a degenerative spondylolisthesis without rheumatoid arthritis. But I have an impression that you see this especially in rheumatoid arthritis patients. I don't know about you, but I have the feeling that I cannot, to be honest, underline with any science or research, but it's a gut feeling. And as you can see in the CT images, the screws are very loose. They are not fixed in the spine. So I revised this case.
Jarkko,
Please go ahead,
Jarkko,
Alexander.
may I ask a question? If you
Yeah, of course.
if you skip the slide back to the pre-op or post-op pre-op, um, usually when we have stabilization, we are aiming for fusion, and we clearly see that here is no fusion. But sometimes we think to ourselves, well, at least it's more stable than before. But in this case, I think the surgery might have been a destabilizing surgery, although we see implants inside. Um, is there any infection seen here in the lab results preoperatively? Do you do an infectious, or did you have the suspicion of an infection here?
It's a very good question, Alexander. Um, I didn't know the patient before I first met her when she was having problems again and experienced an evident pseudarthrosis. But I checked afterwards everything that I could, and I didn't find any clinical signs or evidence of an infection. But I understand you very well that that if you're looking at the images, that might be an option here, but no clinical evidence of that whatsoever.
Yeah, it's tough. Sometimes you have the feeling that the screws want to go out the way they were brought in because they are going straight back to the skin, and then we see these changes that we usually can't see in a fused segment. But you mentioned
That's true.
2 years. She was somehow satisfied.
Yeah, funny. Spine
Yes,
surgery is
I
sometimes,
often
well,
see this
unexplored.
an image to get the feeling there is a lot of pain in it, and then somehow happy patient. So
Mm,
thanks for answering my question.
yeah, well, let's continue the case. And yeah, good that you mentioned the infection. If we have pseudarthrosis, we always send the screws to the sonification, and we also take some tissue samples for microbiological cultures to investigate the sporadic or occult infection, which might happen and which is known to happen in pseudarthrosis in some cases. But in this distinctive case, the cultures and the sonification remained negative. So there were no signs of infection in this case after the revision either. So this is what I made. I extended the fusion to the sacrum and restored a bit the balance and tried to get everything fused. And 3 months after the operation, the patient was happy again, happy as can be. She was very happy, to be honest. But then this is how it then looked 30 months afterwards. So this is strange, do you think? I think the spine doesn't look very bad 3 months after postoperative or after the fusion. I think it looks quite decent. It might not have the proper lordosis. The lordosis might could be a bit more, but it doesn't explain, in my opinion, the fact that this happens already 30 months after the fusion. So there must be something strange in the spine. And this leads me to my the main case, where I am going to go a bit more into the depth about rheumatoid arthritis and its distinctive features in lumbar and in thoracolumbar and in cervical spine. So this is another patient that I met for the first time in 2021. She was 53 years old at that time. She was already retired due to the rheumatoid arthritis because she had lots of other changes. Her fingers and wrists were already, well, let's say, deformed, and she had had several rheuma surgeries here and there. She was also a bit obese, and she was treated for a long time with prednisolone and leflunomide, which is Arava, as you perhaps know. And she had different decompressive lumbar operations in 2010 and 2013. I think the L4, 5, and L5S1 levels at least. And because she was experiencing persistent pain in the back and in the legs, somebody then performed a L2 to S1 fusion 2017. And also this patient was very happy 1 year after the fusion, and she was really doing fine with this construct. I would again say that this is not very nice. The screws are probably in the pedicles, but not the proper pedicle screws that I would like to use. And the shape of the spine is not very good, to be honest. But as I said, 1 year after the operation, the patient was very well satisfied. But then I met the patient for the first time 2021. It was about 3 years after this fusion. And then suddenly she looked like this. And if you remember my last pictures, the last case, this looks in a way a bit similar, doesn't it? When you look at the L2, 3 level, L1, L2 level, you see this kyphotic slippage again, and that affects the whole balance of the spine coarsely. And now this patient was not happy. She was experiencing severe pain, and she couldn't walk. She was getting paraparetic. Her feet were not functioning very well anymore. And of course, in that emergency case, we performed the CT, which looked like this. There were lots of things false and wrong in the spine, as you can see. Not only the L1, L2 level looks horrible, but there seems to be a pseudarthrosis, L2, 3 level, probably L5S1 level 2. The left L5 screw is probably partly in the foramen, tickling the left L5 nerve root. And then there seems to be an L5 pedicle fracture on the left too. And then the MRI looked like this. You see, again, this backwards rolling complete disc in the spinal canal, filling the spinal canal completely and explaining very well the progressive paraparetic symptoms in her legs. So
Jarkko, did I get it right?
yeah.
The patient, the first time you have seen her was in this cauda equina syndrome, and
Yeah,
you couldn't follow her up for several weeks or months. The first contact was emergency cauda syndrome.
exactly. This is how I met her. She was in the emergency department uh, complaining about numbness of the feet and weakness of the feet. And well, I remember she still could urinating was okay. I think she didn't have cauda equina syndrome yet, but she was already partly paraparetic. So, an emergency case. Or is it? Do we have time to do something? Well, because she was not having cauda, I thought we still can wait a bit. We need some more information about this patient. You remember she was using prednisolone for a long time. She was a rheumatoid arthritis patient. She was also immunosuppressed with Arava. So lots of problems. Not only the images look bad, but her medications were not okay. So I decided to do a fast DIXA to see how's the bone quality. And it looks as if her hips were, let's say, low normal, but nothing very serious. So this was first, let's say, a bit better finding. And then, of course, I calculated her balance. It was horrible. The CAP score is 13, but this is not the issue of this presentation. And then we waited a bit to wash out the Arava and see how it goes. But she was not getting better with pain medications. She was paraparetic, progressive. So the question is, what should we do? I think this is a good time to ask you some questions. What would you do in this case? You have lots of problems in the spine. I told you the balance is horrible. L1, L2 has collapsed. There seems to be pseudarthrosis here and there. The screws are not where they should be. There is a L5 spondylolysis with the slippage and L5 root problems, and there is a fracture of L5 pedicle on the left. What would you do, Alexander?
This is Jarkko. This is a perfect question. What would you do? Because I was counting the problems, and you know this famous song, "I got 99 problems," but you told
Mm.
me the osteoporosis is none. So I think the DEXA score will not tell me really what is the bone quality, because this is
Mm.
only bone density, not bone quality. We see here insufficiency fractures in instrumentation, screw loosening. Um, these patients I treat with rheumatoid arthritis are really black boxes, because how to differ between inflammation and metabolism. This is also always a close correlation. um, we control inflammation with the medication, but the metabolism is in general pretty bad. I don't see patients with good bone quality when they have all these biologics and steroids for years. So what would I do? Of course, after talking to the patient that this situation usually only produces the wrong decision, the best advice is, of course, the decompression. There's, I think, worldwide consensus. We have to decompress the segment L1-2 and free the neural structures. The myelin, I think, ends on L1, maybe L1-2. So we have to make a proper wide decompression. We see the kyphosis, the proximal kyphotic failure, the PJF, and the hyperlordotic segments above. So where to end the uppermost instrumented vertebra for me with your measurements and the gap analysis, no matter where we end, will be still unbalanced because this patient usually would need an osteotomy deep down L4, L5 to correct the sagittal balance. But that's not the right surgery for this emergency situation. So maybe I would talk to her and go to a T10 pelvis and decompression. I think you have to revise the complete construct within what is in. I think maybe one screw um, will not be loose. I guess 8 of 10 screws are loose. Convert them with thicker and longer screws. It is a surgery that takes me, I think, 8 hours, 6 hours. It's a long surgery. We know that these patients will not have the best coagulation, maybe cell saver. It is, yeah, I don't want to start this surgery at night. So it was wise. It was wise for me, in my point of view, not to rush into the OR. But the infection rate will be high. It's a long, big open surgery. But I can hardly imagine that any endoscopic discectomy solution will work in this deformity and, yes, let's call it instability. So these are
Wise
my
words. Yeah.
very short ad hoc analysis. If you would go to T10, T12, T8, I think you will not make her balanced from the sagittal balance point of view. There's no right. There are only wrong solutions, I guess. But
I'm
we
not
have
sure
a
if
good
there are only
theory.
wrong solutions, but perhaps bad solutions, because I mean, this is a tough case, and I mean, you have to make rather fast decisions in order to save something and help the patient and not making the situation even worse. So I sat down, I watched everything, all the images very carefully through, and planned what I should do, and then I performed a surgery. Well, let's say half emergency surgery, not during the nighttime, of course not, but during the daytime. I think 1 week and 2 weeks later, after I saw her for the first time, and this is what I did. I tried to correct every problem that she had. And, I, for example, used that miserable situation in L1, L2 level and take advantage of it in a way, and performed a half PSO of L2 to make that kyphosis better. I had to go into the spinal canal very big because the disc was there. I had to take it out, and I need space for that. And if you do the space there, you can then at the same time really perform a kind of PSO to correct the whole deformity there, and then take care that you have enough bone transplant in the front to ensure the fusion later. So then I also broke the L4-5 level in order to get more fusion from there, more lordosis from there, and in order to ensure the fusion also there, I changed the screws, and then I didn't go to T10 or T9. I went up to I think this is T4 or T3, because I was afraid that she would decompensate and have a PJK very fast after the operation. Well, even though we go high in thoracic spine, we still have the PJK and PJF problem. And there are actually studies that show that the risk for that is not any smaller than ending at T10. But at that time, I was afraid that if I go to T10 only, this will break fast, because we were correcting a very severe kyphosis. And, in my experience, if you correct the severe kyphosis and the SVA is very big, and you correct it during one day, the stress that the patients are experiencing at the T10, T11, or T9 level is very high. And the fastest PJK or PJF that I have experienced was already, let's say, 1 week after the operation, or even less, 5 days after the operation. So in this case, I decided to go upwards. And this operation went well, against all the odds. She didn't get any infection. She didn't get any immediate complication after the operation. It went well. And she was actually very happy 3 months after the operation when she visited me at my outpatient clinic, and when she was recovered from the, let's say, rather big operation. I think this took 7 or 8 hours, the whole procedure. What do you think? Do you agree, or did I do something wrong?
Yeah,
Would you have?
that's an
What are your
excellent result.
comments?
This is an excellent
Well,
result.
I
I
would say
didn't
not
expect.
result, because we don't know about the long result.
Yeah, but I was not expecting that the balance looks so good. I can't identify C7, but maybe it's still a positive SVA from some
Yeah,
centimeters. But when you look how the hips are, the centers of the hips, it looks really amazingly good. I didn't expect this. So
it looks decent. Yeah,
yeah, my commands are usually, as I am non-believer in DEXA in rheumatoid patients, I would have used some cement for better fixation for the UIV, and maybe the PJK prevention one above, but up there, T3, T4, cement augmentation is, I feel a little bit uncomfortable. So T6 is no problem, but T4, T3, T2, cement augmentation is a special thing. But wow, what a result! Osteotomy, interbodies, quad rods. You followed all the recommendations we have in our deformity calls. Looks very nice. Well done.
yeah. About the cement augmentation in the proximal end, I used to use cement augmentation a lot several years ago, but then I was a believer in that. But then the first reports came that it doesn't really help, and then at one point I just quit. I have an impression that even though I used cement, I still experienced PJKs. In some cases it worked well, but then in others not so well. So, but then let's continue.
Last comment, Jarkko,
Yeah,
because this is really something I learned from January at Basel. The perfect
yeah.
alignment of the quadrods. It looks very nice. Sometimes you see solutions where the quad rods, the accessory to rods, are more straight. They are not bent so nicely, and I think you can see here now some kind of carpentry. This is skills I learned at January. To from the lateral view, you think it's 2 rods, but these are 4 rods, hiding these accessory rods. Using physiological or likely physiological curvature looks very nice.
Okay, then let's continue. And now I just will hop over one slide to another to explain how it goes further. We can discuss then afterwards a bit. So this is then 6 months later. As I said, 3 months after the operation, she was doing fine. No problems whatsoever. She was happy, and the paraparesis was already almost completely recovered. But then 6 months later, she suddenly experienced problems, and the legs were getting paraparetic again. And now, as you can see, we have a similar happening at the upper thoracic spine as we had in the upper lumbar spine just before. So a PGF and spinal canal encroachment and the stenosis and the clinical signs of paraparesis. And she was having a lot of pain. And if you are looking at that disc again, you look at the disc space T3, T4, or is it, let's say 2, 3, 4, 5, 6, 7, 2, yeah. T2, T4, T2, T3, or T3, 3, 4, you see that the disc has again backed into the spinal canal, and this disc space is rather empty. And this is again the same thing that we have seen in the previous pictures. The whole disc goes backwards. And in this case, I didn't have any other solution than, continue with operating and extending the fusion upwards. So, you know, PJK and PJF after long fusions, they are still a major problem. So depending on publication and the paper, we have approximately 30% rate of PJK or even PJF after a primary long thoracolumbar fusion. And it tends to be even bigger after revision operations for some reason. And you know, risk factors for PJK or even PJF are many. We know many of those, including sarcopenia, which is probably one of the most important reasons, as is osteoporosis too, and thoracic hyperkyphosis, and the preoperative big SVA over 10 centimeters. So you have to remember that the rheumatoid arthritis patients often have all of these, and they, in a way, accumulate the risk for PJK or PJF or these kind of problems. So this didn't actually then surprise me at all. So we were prepared, and when I extended the fusion up to the C7 by using extra rods and connectors, it was difficult up there to just continue with the end-to-end connectors. I had to cut the rods in the middle of thoracic spine because I thought that the stress there is less, and I can rely on the connectors and extra rods there, and then use good rods in a cervicothoracic junction to rely on the stability there. And this is how it looked then after that first revision, and it went quite well. She was happy again. These rheumatoid patients, they are amazing because they are very often very fast, very happy. But then the next problem, the extra rods and the connectors didn't hold, and she developed a pseudarthrosis at the T8, T9 level, and the rods were broken, and she was having pain a lot. And I was afraid that the rods will penetrate the skin and we will have an even bigger problem. So I decided to revise this straightforward, and I opened the whole wound, even though I wanted to avoid that in the last revision. for that reason using only the extending rods from the mid-thoracic spine upwards. I now decided to open the whole wound and use long new rods again, and then it looked like this. And she was happy again, but then the expected happened, and she experienced a wound infection after this operation. It had to come at one point. So the wound was infected, and we had to wash it out surgically once, and then gave antibiotics, I think 3 months, and then it healed. And then I thought, well, now we have everything okay. But again, the T8, T9 level caused problems. It didn't fuse, and it caused another breakage of the rods in 2024, which I then, because she was so painful, revised with first, or let's say my colleague revised it first from the back with extra rods, connecting rods. And then a bit later, I made a thoracoscopic anterior BMP2 augmented fusion T8, T9 to ensure the fusion at that level and avoid another rod breakage. And now she was doing fine. Now she was doing fine again. And I was actually happy. This must be the end result now, without knowing about the future. Pseudarthrosis then is another problem. BJK is one, and pseudarthrosis is another problem. It used to be a high in a past time, 15, 20 years ago, in these long fusions. Every fourth patient had a pseudarthrosis and broken rods. And nowadays we use a lot more anterior augmentations and fusions and cages and different good methods. So we have been able to reduce the pseudarthrosis rate to, let's say, 12, 13, 14%. But then if we have to revise a pseudarthrosis, it commonly tends to persist after the revision, and up to 25% of revised pseudarthrosis cases end up in broken rods. And also pseudarthrosis, as I showed you before, pseudarthrosis tends to be a greater problem in rheumatoid arthritis patients, as you can see in this example case also.
Jarkko,
So,
Jarkko, may I ask you, can you give us some tips? What do you do in the case of pseudarthrosis to achieve fusion if you just go posterior? You now showed a case where you had an anterior support with the cage, but if you only do the posterior revision with the rods, how do you try to achieve posterior fusion? Is BMP2 a topic, an issue for you, or do you use iliac bone crest? And how do you manage to peel off the scar from the bone to get a contact to the bone for the grafting?
Very good question, Alexander. I think that if you try to do the fusion very well at the first place and it still doesn't fuse, there seems to be a problem in the back. And then if you go again to the back and try to get it fused again, I think that, as the science and research has shown, the risk for persisting pseudarthrosis is big, even though you try everything from the back. So I would not rely on meticulous scraping off the scar and revealing the bone and doing everything again to achieve the fusion from the back alone. So if it doesn't fuse in the first place, I then very often go straight forward to the front no matter if it's cervical or thoracic or lumbar spine, I try to achieve the fusion from the front, as I then did in this patient also with the thoracoscopic caging. The same in the lumbar spine. I go to the front. If you can do it from the back using a good cliff cage and a good bone transplant, let's say iliac crest, as I have learned in Basel at that time, that's good. But if you have already performed the cliff that doesn't fuse, then I think you have to go to the front and do it from the front. You can do it much better from the front.
Yeah, my experience is well, sometimes we are preparing in the scar, sometimes using the monopolar electrocautery, and you're happy because it's not bleeding that much. Because preparation in the scar means you're preparation in white tissue, and it's bleeding is not a really problem if you go there the second time or the third time. But
Yeah,
this is just an illusion because it has to
exactly.
bleed. If you want to
Exactly.
achieve fusion, you have to bite away all the scar until you have cancellous bone, and then the bleeding occurs, and then it's proper preparated. And this is in a difficult situation. We have to stick to the rules that bone fusion needs exposure and at least deperiostization or decortication of the grafting site.
Exactly. So let's continue with the case. So now I thought that we have dealt with the thoracolumbar spine and everything should be okay. And she was doing fine with the thoracolumbar spine, no pain there, no problems there. But then she was not happy with the neck. And as you can see in this series of images from 2021 to 2024, you instantly notice that something is happening with the cervical spine. I understand that it's very difficult perhaps to see the details online in perhaps your smaller screens, but already back then when I first met this patient, I noticed that her cervical spine was not good. She has subluxations, olesthesis there, and it looks very rheumatoid. And because she was not explaining or complaining any pain or problems in the cervical spine, I didn't pay any attention to that during the course of other operations and revisions in the thoracolumbar spine. But then at the same time, like unnoticed, something happened with the cervical spine. And now, if you look at the 2024 image, we have a, let's say, classic drop head. And here, then in 2025, she came back again, and now she said that her neck is hurting a lot, and she cannot look straight forward anymore. And she was having tetraparetic symptoms, progressive. So here we have the flexion extension images, active flexion extension images, and you see that nothing happens there. She tries to extend her neck and head in the image in the right, and you see nothing happens. Nothing happens. So what do you think? Of course, we performed the image, and now you can see the very rheumatoid cervical spine and a subluxation of C3 over C4 and a severe spinal stenosis with the signs of myelopathy in C3, C4 after the C7 pelvis fusion. So, the final question, what now? Anybody?
This is this is the final question. At least it's again, it's very easy that decompression has to be performed, and
Yeah.
usually a deformity situation like this, a kyphosis, is usually treated best from interior and gets a secondary posterior support. In this case, it will be challenging, but I think it's somehow probably best to do a corpectomy of C4, get a proper decompression of the level 3, 4, and 4, 5. Although 4, 5 isn't that narrow, but 3, 4. You can also advocate for a posterior laminectomy to free the spinal cord up there. But the toughest question in a rheumatoid arthritis will be where to land with instrumentation. Usually,
Mm.
C2
Your
is the
suggestion?
perfect. Yes, C2 is the perfect landing point for many patients. But in rheumatoid arthritis, the C1 joint is prone to inflammatory and then rapid progressive destructive osteoarthritis as well. So I don't want to go to the occiput. So my suggestion is C1 connection, C1 down. But first, I would try to restore kyphosis with a little bit traction, and then followed by anterior corpectomy, maybe another intervertebral disc is a cage is possible to just get more cervical lordosis. Of course, we have to look where the trajectories are that the patient is getting a horizontal gaze and not become a stargazer. It's tough. It's really tough.
Yeah, exactly. Well, we went to the OR, and we had a plan. Let's try in an OR with the image intensifier to see if we can extend the spine enough to a satisfactory position and satisfactory lordosis. And then if that would be the case, then I said, let's do only posterior fixation and posterior laminectomy to avoid any further operation with this patient. And then in the OR, we noticed that we can extend the spine quite well, surprisingly well. It's rheumatoid arthritis. These spines tend to be flexible, or you can manipulate them. And I did that, and this is the image intensifier picture from the OR after the operation. I went to C2, and I discussed about this with patient, and there are lots of different choices. You can go to the C2. I think the lowest you can go is C2. You cannot do anything else. The lowest is C2, or you can go to the C1, or you can go to the occiput. If you go only to the C2, the next problem we will have is the C1, C2 instability at one point. I agree. And that's a bad thing. But then on the other hand, I do not see into the future very well, and it might be that this patient does quite well after all, or for some time, and can recover from these surgeries that she has had in the past 5 years. Or then you go straight to the occiput, but then that's also very cumbersome for the patient, as we all know. That is something to avoid if possible. But I think if she's going to develop an instability in C1, C2, then the next operation will be the definitive operation to the occiput. And that was my reasoning here, why I now stopped at C2. But I am very well aware that this might not be the last operation. And the learning from this very, let's say, intensive case is that you have to be very careful with the rheumatoid arthritis patients. This all started from one level, the compressions, and now we have a fusion from C2 to pelvis, knowing that there might be something coming up in the near or a bit far future. We will see. But because I operate a lot and I spend a lot of time in the OR, I like to think during the operations, and I like aphorisms. And now, this is something that came up years ago, that you just have to understand the reason for complications and problems that might occur with the patients to know how you could have avoided it and how you now have to deal with it. And with these words from a spine surgeon from Kuopio, I would like to end my presentation about rheumatoid arthritis patients, and I'm happy to answer your questions or inquiries if you have some. Thank you.
Thank you very much, Dr. Halme. Thank you very much, Jarkko. This was an incredible case. These were all the cases were incredible, and I think you really highlighted in the end. Patients with rheumatoid arthritis are a special kind of challenges for a spine surgeon. Inflammation, metabolism, biomechanics. We have to not only know the rules, but the pitfalls much better. And of course, it's interdisciplinary because you can't handle all these medications, dose, interactions, side effects properly, when to switch from one biologics to the other. What about the kidney function? And what is the hip saying and the knee? Because we all know that the hip and the knees or some other joints are on their biological way. And I have patients, of course, some spine surgeries, but in between there was this hip replacement and the knee replacement and the other hip replacements. It's really challenging. But you mentioned these patients often cope very well with complex surgeries, doing great. And it is really an incredible case. Jarkko, I just said I would stop at C1 as a compromise. Knowing that the function of the C1-2 joint is very worth to be preserved, and the patient can regulate a lot by rotating and flexing extension of the head to be able to read, to be able to talk at the table, to watch TV, to walk, and knowing who is approaching, what is the traffic sign showing. All these factors are so important. We may not take these functions away. So C1 was just a compromise. Jarkko, when you look back to your career, and then the next patient comes to you, and the next new patients with rheumatoid arthritis, would you stop at T2, T3 again, or would you have a long talk with the patient and tell her, listen, I have never gone from C2 to the pelvis in the first surgery, but I recommend this now. Would you think that a surgeon who goes to T2 at the very first surgery is kind of over treating the patient, or is he just wise and skips several revision surgeries for PJK and pseudarthrosis?
Several years ago, I visited Dr. Lenke in New York, and we were operating there together, and it was a Parkinson patient case that was primarily operated and fused from C2 to pelvis. And I was thinking, hey, what is this guy doing? I think that doesn't fit my way of thinking, knowing, of course, that Parkinson patients tend to need a bit longer fusions. The old saying, you have to go the whole way. But then primary operation C2 the pelvis, well, that didn't fit into my head at that time. Now, several years later, I see that I am dealing with the same patients, and I'm figuring out what to do with this. But to be honest, no. When I'm operating degenerative deformities, I try to avoid really long fusions. Go to T11, T10, T9, but not higher if there is not a very good reason for that. And in this regard, rheumatoid arthritis patients are not different. The only difference is that if you start with these patients with fusions at some point, even though with small ones, you have to be aware that you at the end might need to go the whole way.
Yeah, the risk is a lot higher. Do you treat patients with rheumatoid arthritis different by post-op bracing, casting? Do you use orthosis in rheumatoid arthritis?
No, not at all. I would say that the only difference to treat this is to be more conservative and try to avoid bigger operations. I am very strict with my indications, and rheumatoid patients even stricter. The only thing is that they usually have severe findings and you have to deal with them. You have to do something because they are so painful and they are experiencing even paresis symptoms. So you have to do something. But I try to be rather conservative with rheumatoid arthritis. If I see a patient with rheumatoid arthritis, I try not to operate if it's not very necessary.
Yeah, and the last question I have is optimizing preoperatively, postoperatively the bone metabolism, because all these proximal junctional kyphosis, I think there is also the weakness of the bone, the osteoporosis, the metabolism is important. Do you prefer putting them for 2 years on teriparatide or denosumab? Is there any consensus with the rheumatologists what to do with the bone quality, the bone metabolism?
Very true. We in Finland, we have lots of Rheuma patients. We belong to the countries with most Rheuma patients in the world. And that has led during the decades to a very good system. It's, I have the impression that the Rheuma patients in Finland are taking very well care, and that includes only the also their bone quality checks. The rheumatologists, they really check these things, and all these patients, they already have the osteoporosis medications on when they come to my office. So I don't have to deal with that a lot. So I almost rely on our rheumatologists and see that it has been taken care of. The only thing is, if I am planning a bigger operation, deformity correction and long fusions, then we always check the DEXA as a part of the normal and standardized checkup before the operation.
Yeah. Thank you, Dr. Halme. Thank you, Jarkko. Thank you for your talk from Kuopio in Finland. The upper uppermost northern host guest I've ever had. Thank you very much for your lecture late at night. Next week we will listen to another guest. You will find the announcements on social media, on X, on Twitter, or on LinkedIn. And thank you again, Jarkko. Thank you to the audience for staying tuned in. I see I see Mr. Bernstein. Um, See you next week. Thank you again, Jarkko, and goodbye. See you.
I thank you all very much. It was a pleasure, and hope to be able to share some insights into rheumatoid arthritis in spine surgery. Thank you, and have a nice day or evening or night wherever you are. Thanks, Alexander,
Thank you.
for the invitation.
Thank you. Vielen Dank, Jakob. Sehr schön gewesen.